Welcome to the recorded version of The Messages We Send, Stigma Toward Persons Living with Dementia and How to End It, from May 7th, 2019, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thanks so much, Steve. Welcome everyone to the webinar today, The Messages We Send, Stigma Toward Persons Living with Dementia and How to End It. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. Thank you so much for joining us for this very important topic today. I want to thank Drs. Stites and Hummel for giving us their time and expertise on the issue that we're going to discuss today. So without any further ado, thank you again from the Administration on Aging. And back to you, Sari.
Thanks, Erin. For today's webinar, as you just heard, we'll hear from Dr. Shana Stites and Cynthia Huling-Hummel. They'll introduce themselves as they begin their presentation, and I'll turn the webinar over to both our presenters at this time.
Thank you. Good afternoon. It's my pleasure to be here with you today to present on the topic of stigma and language. The title of today's talk is The Messages We Send, Stigma Toward Persons Living with Dementia and How to End It. I am joined today by my co-presenter, Cynthia Huling-Hummel. I'll begin by briefly introducing myself, and then Cynthia will introduce herself. I am a clinical psychologist and a researcher at the University of Pennsylvania. My work broadly focuses on understanding how advances in diagnosis and treatment of Alzheimer's disease and other brain diseases impact the psychosocial well-being of individuals and their families. Cynthia, would you like to introduce yourself?
Sure. I'm a retired Presbyterian pastor, and I currently serve on the National Council on Alzheimer's Research, Care, and Services, and I've presented at 2 of the research summits. I'm passionate about research, and I've been in an Alzheimer's study for 9 years.
Thank you, Cynthia. We hope that by the end of our presentation, you'll be able to describe and define types of stigma associated with dementia, describe the role of language in stigma of dementia, define what it means to use a strength-based approach in how you talk with and about persons with dementia, and lastly, that you'll be able to give examples of person-centered language that counters the stigma of dementia. The format for our presentation today is that we will cover 3 topics. We're going to give you a grand overview of dementia to begin, then talk about where stigma of dementia comes from, and then lastly, move in to talk about what we can do to end stigma. In this last part, we're going to focus specifically on language. Let me begin by defining dementia. Dementia is a chronic and progressive neurodegenerative disease. It includes impairment in at least one domain of cognition. Dementia refers to a set of clinical symptoms and signs that can be attributed to any of a number of different underlying causes. The most common pathology that causes dementia is Alzheimer's disease. About 60% to 80% of dementia is caused by Alzheimer's disease. Dementia can also be caused by one or more of a number of other pathologies, such as vascular disease, Lewy body disease, and others. Dementia is clinically distinct from something called mild cognitive impairment, which is thought by some to be a precursor to Alzheimer's disease. And it's also distinct from delirium. Delirium is an abrupt and short-term change in cognitive status. In part because of the different pathologies that can cause it, persons with dementia can present differently. Some of the differences in how they look clinically can be characterized as differences in age of onset, family history, and the initial symptom they experience. Dementia is unique from other conditions, in particular in how it can impact others beyond the person who is experiencing the condition firsthand. Often, these secondarily affected persons are family and close friends who may step in to help. These individuals are often referred to in the medical and social service system as caregivers. A caregiver is a person who has a formal or an informal role providing care to a person with dementia. The care they provide often includes any of a range of activities of daily living. caregivers are most often spouses and adult daughters of the person who has dementia. In part because of their dual roles as spouses and children, and in part because of the wide variety of ways that they may step in to help, they don't always self-identify as caregivers, but rather they may prefer to be identified by what they see as their primary role in that individual's life, such as a wife, a daughter, husband, or son. The role of helping a person with dementia has benefits and consequences. Some of the benefits you might want to consider is that caring for someone you love can provide a sense of pride in passing along traditions and a genuine sense of just caring for this other person. It can also, in some cases, bring around physical activity, going out on walks with the individual. Consequences can include physical injury and financial hardships, as well as stigma and discrimination. Now, at this point, I'm going to turn the microphone over to Cynthia to tell us a little bit about what it means to her to be diagnosed with and living with Alzheimer's disease dementia.
Mm-hmm. Some might be wondering about when I was diagnosed. So I started noticing cognitive problems back in 2003. I was studying for my doctorate. It took 8 years and many, many doctors' visits and tests before I was actually diagnosed with amnestic mild cognitive impairment due to Alzheimer's disease, and that was in 2011. And you might be wondering how I was diagnosed. I was diagnosed after my third round of neuropsychological tests. It was in the spring of 2011, and I was reading my report, and it was very clear that I was at the very low end of the bell-shaped curve across all the cognitive domains. It was really, really hard for me because I had always prided myself on my excellence as a student, and I really felt ashamed and stupid by my poor performance. In 2016, my diagnosis was confirmed with a positive tau PET scan, which was performed through the ADNI study. And I'm in my 9th year. It wasn't a huge surprise, but it was sad. Alzheimer's runs in my family, and I carry 2 copies of the APOE4 gene. What did it mean to be diagnosed? Oh, in many ways, it was a relief, but in that I wasn't imagining my difficulties. They were real, but it was tough. My mother had Alzheimer's disease, and she passed away in 2014. And what's confusing about that and what made it tough for my family and friends is people were questioning my diagnosis. I couldn't have Alzheimer's. It didn't make sense to people because I was functioning so very well in my life. And people were actually arguing with me about my diagnosis being wrong and they actually suggested that I was exaggerating my symptoms and I was really seeking attention. Some might be wondering if anyone helps me in my day-to-day life. I'm pretty independent still. I'm able to live and travel on my own. I've been looking ahead for care communities, ones with a graded care system, so that as things get harder for me, that safety nets are already in place. I don't really want to burden my family in any way, and I've already worked with an elder care lawyer to put a plan in place, and I have a circle of support, my nearby friends who I can count on to notify my family of changes, and they're going to help me know when it's time for me to transition to the next level of help that I need.
The fact is, Cynthia's experience of being diagnosed with Alzheimer's disease is similar to that of many people. It can be inefficient, taking many years, and uncertain as to whether the diagnosis is actually the diagnosis. The process for identifying dementia has remained virtually unchanged for the last 100 years. As Perel described in 1998, the dementia of Alzheimer's disease is typically gradual in onset, so insidious that families and the afflicted individuals may not recognize the disease until glaring deficits have appeared. I'll add one thing here, in that this description may also be true for clinicians who may not recognize the pathology until enough of the symptomology is observable that the diagnosis can be certain. That has been the general experience of diagnosis up until recently. Now it's beginning to change. Advances in biomarker-based diagnosis are allowing for earlier identification of the disease, in some cases even before the emergence of symptoms. What you're seeing here is a graph. The graph shows on the far right a brown line that depicts how diagnosis of dementia was made based on the increasing impairment in clinical functioning. On the left, the graph shows with the red and green lines how biomarkers like amyloid and tau can allow for earlier identification in these preclinical stages of disease when people may not be showing symptoms or signs yet. These are recent developments and still emerging. Like Cynthia said, she learned her result from a tau PET scan when she was part of a research study. A diagnosis, no matter the stage of disease, is a social signal that can lead to a person being treated differently by others. This differential treatment is often pejorative, whereby a person is treated inferiorly because of his or her diagnosis. This is called stigma. There are three broad types of stigma: internalized stigma, public stigma, and spillover stigma. Much of what Cynthia and I will be talking about today falls into the categories of either internalized stigma or public stigma. Internalized stigma is when negative beliefs and attitudes associated with a characteristic, like we're talking about here, a diagnosis, can impact how a person feels about him or herself, and even what they expect of themselves and how their brain may work and what they're capable of doing. Public stigma is when others demonstrate negative feelings, beliefs, and behaviors toward a person based on a characteristic understood to be negative. In this case, we're talking about a diagnosis or symptoms of dementia. And lastly, spillover stigma is when stigma generalizes to others based on association. For example, caregivers are sometimes stigmatized because of their associations with a person who has dementia. All three types of stigma arise due to stereotypes and misinformation. Often, stereotypes are grounded in the hallmarks of a disease. For Alzheimer's disease, stigma often relates to being a leading cause of disability that has no medical therapies to slow its progression. In other words, a person with a diagnosis is expected to get worse. So the stereotypes that surround the disease usually reflect the most severe stages of the disease, relating to characterizations of severe memory loss, loss of identity, and loss of significant relationships. Stigma can have harsh consequences. Apologies for that. Stigma can have harsh consequences. The stereotypes and misbeliefs can lead people to patronize, stereotype, isolate, or discriminate against persons with Alzheimer's disease and other types of dementia. This, in turn, can discourage a person from seeking diagnosis, hinder a patient's quality of life once they have a diagnosis. It can discourage individuals from participating in Alzheimer's disease research, and it can stop members of the general public from seeking out factual information. Understanding stigma of dementia may help inform how to change it and or how to help individuals overcome it. I'm going to turn the microphone back over to Cynthia to talk about her experiences with stigma.
So you might be wondering how the diagnosis or being diagnosed has affected me, and it was, for me, one loss after another. It was incredibly hard. I missed being in full-time ministry. I needed to move out of the manse, which is like a rectory, so another pastor could move in, and I moved to a new town. I was so incredibly lonely, and I lost my sense of purpose. And it took me a while to move from why me to what next. But I'm a person of faith, and that means practicing what I preach. But it was hard. And I think the hardest part in the beginning was losing my identity. So much of our identity is tied to our work. And I wondered how to even introduce myself in my new town. How could I be Pastor Cynthia if I no longer had a church? There was a huge stigma around a diagnosis of dementia. And people often view you as simply incapable. They see what you can't do rather than what you still can contribute. They see the diagnosis as a death sentence rather than a person who's still able to live a life of blessing. you might wonder if the stigma has impacted me personally, and people make assumptions that are grounded in stereotypes. As I said, they see you as incapable. They see what you can't do. Sometimes people will speak to me more loudly. Hello, I'm not deaf. There's some events where I'm not welcome because I don't have a care partner, and some of the events mean that you can't attend the event unless you have a care partner with you. And I have been advised not to come to certain events because I might make a caregiver feel uncomfortable speaking about a loved one with dementia. And so that's really that's my personal experience with stigma.
Thank you, Cynthia. How Cynthia described being treated, unfortunately, happens to a lot of persons with dementia. My colleagues and I at the University of Pennsylvania are studying this, and I'd like to share with you some of what we've been learning about Alzheimer's disease stigma. I'm going to present to you results from 2 different studies. In this first study, we conducted an online experiment where we randomized about 1,000 members of the general public to read one of 9 vignettes that described a man with mild Alzheimer's disease, traumatic brain injury, or who was not given a diagnosis. We also told respondents that his prognosis would worsen, improve, or remain unchanged over time. After respondents read the vignette about the man, they answered questions from the Modified Family Stigma in Alzheimer's Disease scale. The scale asked questions that measured 7 topics, and I'm going to talk about each one briefly. 1, structural discrimination. This was a scale that relates to worrying that the person described in the vignette would encounter institutionalized discrimination. That's discrimination by societal systems, agencies. Negative severity attributions. That's expecting that the person would show certain symptoms like speaking repetitively or suffering from incontinence. In some cases, these symptoms were more severe than what would be expected on average from a person with mild stage Alzheimer's disease. Negative aesthetic attributions, expecting poor hygiene, neglected self-care, and other appearances that provoke negative judgments. Antipathy, endorsing feelings of disgust or repulsion about the person. Support, expecting others would feel concern, compassion, and willingness to help. Pity, expecting others would feel sympathy, sadness, or pity for the person. Social distance, expecting the person to be ignored or have their social contacts limited, not invited to family gatherings, or asked to participate in other social activities. On this scale, across each of these domains, higher scores indicated stronger endorsement. I'm going to share with you 2 sets of results from this study I just described. The first set of results will be from the full sample. The second set of results will be from a subset of those people who read only about the man having Alzheimer's disease. Here, what you're seeing on the screen, is the first set of results from the full sample of about 1,025 respondents from the general public. The 2 graphs on the left side of your screen show how stigmatizing reactions differ based on whether the respondent was told the man's condition would improve, remain unchanged, or worsen. As shown in red, believing a person's condition would worsen over time caused greater stigmatizing reactions than being told either that his condition would improve or remain unchanged. In contrast, the 2 graphs on the right side show how stigmatizing reactions differ based on whether respondents were told the man's condition was caused by Alzheimer's disease, traumatic brain injury, or given no diagnostic label at all. They show that being told the diagnosis was Alzheimer's disease caused no significant difference in the reactions as compared to TBI or no label. Now here's the second set of results from only the subsample of about 317 people who were told explicitly that the man had Alzheimer's disease. They show that members of the general public reacted to him, members of the public reacted to him differently based on who they were. For instance, men tended to make stronger negative judgments about the person with Alzheimer's disease's aesthetic attributions as compared to women. Women tend to express more pity for an individual with Alzheimer's disease than men. And lastly, on the far right, those who believed more strongly that Alzheimer's disease was a mental illness rated that the person in the vignette had more severe symptoms than individuals who held this as a weaker belief. Now let's talk about the second study that I mentioned. Here we studied people who were diagnosed with mild cognitive impairment, mild stage Alzheimer's disease, or had normal cognition. We asked them questions to determine whether they were or were not aware of having a diagnosis. We were relaxed in our criteria for doing this. For example, if they told us they had mild cognitive impairment, but the records showed that they were diagnosed with Alzheimer's disease, we counted this as being aware that they had a diagnosis. Let me also say that as part of classifying individuals as being aware or unaware, we also classified them based on cognitive testing for those who had normal cognition, mild cognitive impairment, or Alzheimer's disease. Those who were aware of their diagnosis performed similarly on these cognitive tests as those who were not, or those who were unaware. The results of the study also showed that persons aware of their diagnosis reported greater depression, greater anxiety, and more stress than those who were unaware or cognitively typical. This is shown here by the green diamonds that are well above both the red and blue diamonds. These results show how internalized stigma and our expectations that are associated with a diagnosis can significantly impact how a person feels. So let me transition now so we can talk about what to do about stigma. There are a lot of things we can do to reduce stigma of Alzheimer's disease and other dementias. Let me share briefly a few of the initiatives my colleagues and I are doing. First, we organize art exhibits. These are called Art of the Mind, for artists who are living with cognitive impairment to showcase their work. This program shows off the creativity, power, and productivity of individuals living with cognitive impairment, as well as in some cases, their art allows others a glimpse into the world of what it means to live with cognitive impairment. We use the results from our studies, like some of those results we talked about today, to develop interventions to reduce public stigma. Here, you can see one of the public messages created based on the results of a study that was designed to learn what beliefs stopped and facilitated adult children from accompanying their parent to a memory care visit. These messages are tailored to an audience based on the audience's demographic characteristics, attitudes, and beliefs. We work to get out factual information about dementia and cognitive impairments. For example, we distribute an annual magazine that personalizes the experience of living with dementia, offers facts about what it means to live with dementia, describes the latest research opportunities, and other key topics. We also use a range of social media platforms to get out those messages to a broad audience as possible. The last one that I'll share with you today is that we often write guidelines and recommendations to share with clinicians who are caring for persons with Alzheimer's disease and other dementias. These write-ups explicitly address common misbeliefs and provide concrete action steps to avoid perpetuating stigma. Now, as I hope you can see, ways to reduce stigma of dementia can take many different forms. but they all often share one thing in common. Words. The words we use either perpetuate or disrupt stigma. Word choice that perpetuates stereotypes, objectifies people, marginalizes, invalidates, dismisses, all of those drive stigma. In contrast, words that respect an individual, personalize and validate experiences, foster dignity, and help individuals access self-care, push back against and disrupt stigma. Our words often reflect the frameworks we use. Two textbook examples of frameworks that can inform our lives are the religious model and the medical model. The religious model can promote phrases like afflicted with or stricken by, or that a person suffers from. These phrases reflect a belief or convey a belief that the condition somehow resulted from a divine judgment, or that the person is a victim or somehow morally deviant. The terms assume that a person is suffering or does not have a meaningful quality of life. The medical model promotes language that sees individuals as patients with a sickness or a disease that needs to be cured. The medical model also often leads to identity-first language. This is when a person is referred to as their condition, like someone is demented, is a schizophrenic, and so on. There is also a framework for language that is the antithesis of stigma. It's called person-centered language, or PCL. The purpose of PCL is to recognize the impact of language on thoughts and actions, to ensure language does not diminish the uniqueness and intrinsic value of each person, and to allow a full range of thoughts, feelings, and experiences. PCL is also sometimes called person-first language. There are 6 guiding principles of person-centered language. Here on this screen, you see the first 3. The first one I'm going to talk about is personhood. This is a standing or status that is bestowed upon one human being by others in the context of a relationship or social interaction. It implies recognition, respect, and trust. The second is dignity and respect, whereby we create positive conditions where a person can live without fear of shame or ridicule, where people are treated with warmth and authenticity, listened to without judgment, and are given opportunities for independence and self-expression. The third is acceptance and understanding, where a person is accepted with unconditional positive regard. Behavior is accepted as a form of communication that expresses unmet needs or emotions and helps the person continue to enjoy basic freedoms. The fourth principle is relationships. This is where we act to support, preserve, and develop positive relationships. Next, recognition and individuality. That is, we recognize the individuality of a person's unique life experiences, personality, culture, values, beliefs, and opinions. We respect and incorporate these factors in the person's future care planning in their daily lives. Lastly, we build relationships of trust by providing conditions necessary to satisfy fundamental needs and create a climate for personal growth and understanding. In a relationship of trust, the person knows confidences are respected, choice and control are maintained, and the person will not be abandoned. Historically, language used to talk about dementia and people with dementia has focused largely on losses: the loss of ability, the loss of identity, and the loss of self. This can promote perceptions, interpretations, and approaches that focus on weakness rather than strength, illness rather than wellness, and being victims rather than whole persons. PCL is a strength-based approach. It moves the focus away from deficits and towards strengths and resources of a person. Here are some examples of language that promotes stigma and the person-centered language, PCL, that can replace it. For example, avoid referring to persons as inanimate objects, conditions, or diseases. You may think, well, I would never refer to a person in this way, but it actually can be quite common, where people might refer to another as being demented, that someone is demented. In that case, we are referring to them as a condition. That sort of language is a shorthand. We can replace it with person-centered language, such as a person living with dementia. Something you may find as you read down this list is that recommended terms, the PCL form, are almost always longer than the stigmatizing form. Some people complain about that. It takes too long, too much effort, too much breath. But it's actually the other way around. Stigmatizing terms are the short form of longer phrases. When they're shortened, they strip away meaning to something that's less than, more removed, and quite frankly, not worth my time to say. So the better approach is to take the time, show the effort, and use person-centered terms. Cynthia.
Yes.
Can you share an experience from when a person said something that was stigmatizing and what you wish they had said instead?
Oh, yes. Several years ago, I was invited to speak at an event, and I shared my talk with the organizers ahead of time to see if I was on message. And they said the talk looked great, and they would give it to the DJ to read. The DJ. Oh, I was hopping mad. They assumed that I couldn't present, that I couldn't read my own talk. It was my talk. I wrote it, and I told the organizers I would deliver it. And if they wanted the DJ to write his talk, that would be fine with me. But it still makes me mad to think about it. But in fairness to the organizers, I think that they didn't have much experience in working with a person in the very early stages of dementia. What do I wish that they had said? If we could do a do-over, I wish that they had said, Cynthia, we are so honored to have you with us. Your message is so impactful. Thank you so much for joining us. And what do I wish that they had done instead? Well, I would want them to apologize and ask for my help and insight into the matter, to be willing to hear why it was hurtful, and to learn from that experience and to work hard to eliminate stereotypes and hurtful words. Recently, I wrote a reviewer. She had heard me speak, and she had written a review on the talk. And her remarks were really quite positive, other than she referred to me as a suffering person with Alzheimer's. And I wrote her a note saying, could you change the word suffering? Because I'm not suffering, and it perpetuates stigma. I suggested that she might replace it with struggling, because we all struggle at times, and struggling is not a pejorative. And on the subject of language, please don't refer to me as an Alzheimer's patient. This happens all the time. So Cynthia, an Alzheimer's patient. I'm not in a hospital bed. I'm living in your community. And if you're my doctor and I'm coming into your office, okay, I'll accept that label. Otherwise, please introduce me as Cynthia, not as an Alzheimer's patient. Thanks.
Thank you, Cynthia. As Cynthia describes, there are some everyday strategies we can use to make sure our language is person-centered and supportive of persons with dementia. Like Cynthia suggests, take time to eliminate outdated and offensive words from your vocabulary. Avoid using the language of disability to describe potentially negative traits. We can avoid words referring to people as inanimate objects, conditions, or diseases. We can take time to understand why individuals may prefer person-centered language over identity-first language, even though it can be longer to say. We should recognize, or we can recognize, our cultural assumptions. Examine and re-examine the stereotypes that promote stigma. Ask yourself, what do you believe about this disease and persons who may have this disease? Find out and care about the preferences of other people. The better you can come to know an individual, the less you'll have to worry about generalizations and misinformation. Because when you talk to them, you'll talk to them using the specifics of their experiences and what you know about them. And lastly, we all make mistakes and misspeak. Most people don't mean to offend or hurt others. We can apologize, we can learn from it, we can move on. And if we're on the other end of one of those misstatements, we can help people learn from their mistake and help them find a better way to correct themselves. We appreciate your time today and want to thank you.
Yes, thank you.
If you'd like to stay up to date on the latest research, please follow me on Twitter. You can also find connections to the Penn Memory Center and our programs from there. Thank you.
Great. Thank you so much to both of you for a fabulous presentation. We do have some questions that are coming into us right now, and I'm going to start asking those at this time. So the first question was asking about how stigma related to dementia can discourage participation in research. Shana, that one's for you.
Absolutely. So we can do that in a couple different ways. One is just to imagine if a person participates in Alzheimer's disease research, then they're saying, there's a meta message being communicated there that they have a relationship to that disease. If others learn of that, there can be a fear that they'll be treated differently. Imagine you're in a trial, a clinical trial, and your employer learns that you're in that clinical trial. Some people could worry, well, what would that mean for my job security? Particularly as individuals age, the reality and the concerns around developing Alzheimer's disease become even greater. And so at some level, when you agree to participate in Alzheimer's disease research, you're holding that, you're taking that on and confronting some of those, what can be very prominent worries that this may in fact happen to you. And for some people, that there's too much stigma, there's too many false beliefs, and there's for one's internal self to deal with it, as well as worries if anybody finds out about it, how they would be treated by others.
Great, thank you. The next question is for Cynthia. There's quite a few questions embedded here, so I just want to ask you more generally, do you have any recommendations of how religious institutions, in particular, how members of those institutions can help reduce stigma based on your experience?
Religion. Oh, I'm sorry, Cynthia, go ahead.
Yeah, I would say there's many ways that one of the groups I'm working with right now is Faith Against Alzheimer's, and working with dementia-friendly communities and congregations in promoting different activities for congregants and people in the community to get involved, but inviting speakers into your congregation to talk about dementia, to open up the doors for different programs, to become more aware of how people in your neighborhood might be served by offering respite care or drop-in opportunities for people to make art or make music. There are many ways that religious communities can get involved to reduce the stigma.
Great, thank you. Shana, do you want to add anything?
Oh, I just wanted to underscore that religious institutions are some of the biggest allies in confronting stigma and certainly in helping to eliminate it. Their core in their communities, how they reach, their reach is significant with the number of people that they engage, and they're respected. People listen to them, and so the language they use, the way they frame treatment of individuals living with dementia, are core ways that they shift the stigma, whether that be for the good or for the bad.
Great, thank you. So can you talk a little bit, Shana, I don't know if the literature talks about this or if you just have some insight, but we have a few questions coming in related to why we think that some physicians may prefer not to tell a person about their Alzheimer's disease or other dementia diagnosis.
The literature does talk about this, and there's a few different reasons. I'd say probably the most common that we run up against is that at this current time, there is no therapy, no drug or medication that can modify the disease. And so for some clinicians, the question is, why would we tell someone? There's nothing that they're going to be able to do about that. I'm not saying I agree, but that is one of the things that you hear. It's a rationale that's given for not disclosing a diagnosis. In other cases, there's a sense of paternalism, where the clinician wants to protect the individual from what they see or understand to be bad news. There was a point in time where physicians and other clinicians did not disclose cancer diagnoses in ways that are very similar to what we see today in Alzheimer's disease.
Great, thank you. There was a question that came in about person-centered language. Are there any guidelines available about person-centered language that you might be able to direct people to, Shana?
Well, there's a couple resources. I don't have them right on hand. There's no national guideline within the United States. I believe the American Psychological Association has some semblance of a guideline that they put out around person-centered language. The American Disabilities Association is another one that addresses person-centered language. And Canada, I believe, actually has a national guideline on person-centered language.
Great, thank you. So there's a few questions that kind of go together that are coming in here. They're asking a little bit about this knowing the diagnosis. So people understand that it's important to know the diagnosis, but given some of the results that you presented, that some people who are aware of their diagnosis may experience greater depression or anxiety or stress, what do we recommend here, and how do you kind of juxtapose that, giving the diagnosis and then the effect of that?
Sure, and I guess in full disclosure, this will be my personal, somewhat, I would say, biased opinion on this, informed by the literature and my research, and as a clinical psychologist, but it is very much my bent on this. I hear that. Getting a diagnosis of Alzheimer's disease, I've heard it referred to as a dreaded diagnosis. It can have a negative impact on individuals. Much of how it's negative, particularly in terms of the psychosocial consequences of what it means to get that diagnosis, to me does not communicate that you hide the diagnosis from the person. It means that we as a society need to change, right? That the issue is on the outside. It's not confirming for the person that there's something wrong with them on the inside in not being able to hear this information. And some of that is grounded in a respect for autonomy. Individuals do lots of things once they learn that they have a diagnosis, and maybe Cynthia, I think, could probably echo some of her presentation, right, and maybe speak to those when I'm done. But who am I as a clinician or otherwise to think that what I know is best in this case? Even around treatment decisions, you offer up possible treatments and the science that goes with them. The final decision is the patient's. And so in this case, the same. I don't take that paternalistic view. I'm not sure what that individual may do with it. I may talk to them first, understand what they're feeling about that, but they may be making life decisions, planning for their future in ways that I could be depriving them by not sharing that diagnosis with them. Is that getting towards the questions?
Yes, definitely. There were quite a few about that idea.
Yeah, I would just add to that there's many resources that are available in our community. I was thinking of the Alzheimer's Association and their 24-hour hotline with trained clinical social workers who answer the questions that people might have, looking to the faith communities for support. There's many of our communities have aging services or services and groups for people who are facing difficult times in their lives and taking advantage of the different programs and services and finding a network that you can plug into to find that support can make a huge difference in how people are able to deal with the diagnosis and move from why me to what next.
Yeah. There's a thank you, Cynthia. That's a very good point. Again, one of the biggest arguments for not disclosing a diagnosis is that there's no current treatment, disease-modifying treatment for Alzheimer's disease. But people can use a diagnosis, and they do often, to make sense of their experiences, both for themselves and individuals around them, their children, their spouses, to understand what's happening and what they may need in the future. These are all very good reasons to disclose a diagnosis and allow that individual to decide what to do with it. I'll stop there.
I would just say yes, having a diagnosis in some ways for me was a relief, because then I could understand why the things that were happening to me were happening and that there was a medical reason. And I was thinking I had covered up my symptoms so well. And when I shared it with my church family, it was like, oh, that explains a lot. But then they were able to be supportive instead of mystified. You see, it just turned it around.
That's great, and leads into a few other questions that have come in. One person was asking, is it a good idea to tell people that that they have an Alzheimer's disease diagnosis? And you just gave a great example, Cynthia, of why that was helpful for you to explain that to those who are in your church community. But there's another question that came that are employer-based. Are there any suggestions about how to approach an employer if a person has a new dementia diagnosis? And then what are some resources available to employers to help a person with in very early stages to possibly remain in their job? So kind of a two-pronged.
Those are great questions. Make sure I have both of them here. So in the first one, it's an individual with a new diagnosis, correct?
Yes, how to disclose that to an employer.
Right. I suppose the first thing is thinking through the process of whether one wants to disclose and what the reasons are for that disclosure. And that's really going to vary from one situation to another. If you feel that you have a diagnosis and that you have an open employer who's willing to have those conversations and figure out how to move forward together as opposed to just react based on stigma, stereotypes, and discrimination, then that's the first step, right? There was a gentleman, a professor at Temple University, actually, who's quite public with his diagnosis. You can find him online just Googling Temple professor with Alzheimer's disease, who went through the process. He had decided, yes, this is what I want to do, and disclosed it to Temple University. And they got together. They had meetings. They talked about what that would look like, what some of the deficits he was experiencing, as well as the things that he wasn't, and so how he needed support in continuing to stay in his role versus maybe some responsibilities that it would be better for him to step away from. They also had conversations together in terms of, Cynthia mentioned this earlier in her talk, the how do you know when you've crossed the line, and maybe I can do it today, but maybe I can't do it tomorrow. And how do I know when I'm at that place where I can no longer carry out some of these responsibilities?
And then being able to have trusted people who can help reflect that back to us. Maybe we're not always the best judge of what we're able or not so able to do, and to be able to have that trusted circle of friends to help us make that call at that point.
Great, thank you both. Yes, that was a great answer. Anything else to add after that, Shana, or should I move on to the next question?
In terms of, I think there was a question about was there a question about the guidelines for employers?
I was just asking, are there any resources you can think of available to employers?
It's nothing that comes to mind. I do know within my professional circles it's a topic that comes up, and there may be some working groups who are trying to hash out this very issue in understanding how one develops guidelines, especially as diagnosis becomes earlier and earlier in the pathology. People may be able to stay in their jobs and work for years. So how does an employer handle that and in a more sort of evidence-based way make decisions of how to support a person and when to move somebody from one set of responsibilities to another.
Great, thank you. Cynthia, an interesting question came through. You may or may not have an example, but was there ever a time where you told someone your diagnosis and it turned out it wasn't a good idea?
I can't think of any specific examples of that other than sometimes I've had people laugh. And I think, thinking it was a joke. So in that regard, it wasn't a good idea. Where people just, that, or they'll tell me a joke, thinking that was a way to make a connection with me. As I'm setting up for a presentation, are you the person with Alzheimer's? I've got a good one for you, as if that might be a way to bond us in that moment, and it was not. But I think people are curious. They've never met somebody in the very earliest stages, perhaps, and it's a new opportunity for them to chat with somebody and what does it feel like, and more of their experiences are with the very later stages. And just wondering, many people use it as an opportunity to talk about themselves and wondering if their cognitive problems might be due to Alzheimer's or a related dementia. And I always encourage them to get in and make an appointment with their family physician, their PCP, to check things out. It quite possibly could be something else that's very treatable, and not to jump to that conclusion.
Great, thank you. There's a question that came through. It says, there are many diseases that can cause dementia, and the question is using a term like dementing disease still stigmatizing? Is there a different way that we could say that?
I think for what I have to lead back with a question of for what purpose?
Dementing disease.
Yeah. For what purpose is it being said? Does that make sense? So
yes.
Specific is always better. And so if you were going to talk about a disease that was causing this process, referring to it as the actual pathology would be the ideal way to do it.
Mm-hmm.
Great, that's helpful. You have anything you want to add, Cynthia?
I was just going to say like a urinary tract infection if it was causing a dementia-like condition, to say this person has a urinary tract infection. Let's be specific. Let's be clear.
One other thing to keep in mind is how we use the term dementia. It depends on the type of work you're doing, but especially when engaging individuals living with dementia, there can be a wide range in how individuals present, both in terms of the underlying pathology that's driving some of the changes and where people are in the disease course, as well as many other factors go into this. And so, again, it's best to be as specific as possible. If there's a particular function or dysfunction or impairment that is on the table, that's the point of discussion, it would be best to focus on what that is rather than referring back to a more global term of dementia.
Great, thank you. Let's see here. Can you talk a little bit more about, Shana, about how one might distinguish between mild cognitive impairment and dementia? Are there any markers that people can look for, any key things to keep in mind?
We're speaking in the general public? It's a question of for what purposes. So the clinical diagnosis, that being made by clinicians, it can be difficult, to be honest, to discern between what is MCI and what is dementia, and sometimes there is sort of MCI with the underlying pathology being attributed to Alzheimer's disease. So it's not easy in terms of being a member of the general public or working in a service organization. I would actually caution and to be conservative in assuming what an individual's diagnosis is or what pathology they have at work. One of the more offensive things that I've heard from individuals living with MCI talk about is that because the term mild is in that diagnostic label, people assume the condition is mild and living with it is no big deal. And it can actually, that's not the case at all. And so there can be a miscommunication based around what, we call it mild cognitive impairment. It's not mild.
Great, thank you. So
if there's clarification to that question, I'm happy to take it.
I haven't gotten any that came through, so we'll go with that. I want to ask one more question, Cynthia, if you could. Someone asked how you might respond if someone asks you, what do you do, as in like a job?
Oh, what do I do? I am an advocate for people living with Alzheimer's. This is actually what I refer to as my ministry. This is what I'm supposed to do, is go out into the community and walk with people in their journey and educate them and support them and help them and refer them to helping organizations. I do a lot of public speaking. I'm an artist. I created 36 masks that illustrate my life as a person who's living with an Alzheimer's diagnosis. I sing in a band. I kayak. I'm a grandma. I volunteer in my community in many ways. I preach in little teeny churches as a substitute preacher. I am a busy person. Yes, I have an Alzheimer's diagnosis, but my life is full of blessings, and really this disease in very strange ways has brought me additional blessings just in the people I've gotten to know and work with, the researchers such as Shana and people who are there on the front lines who are looking for treatments and cures, and so that someday we will have a world without Alzheimer's. We're not there yet, but the underscore word is yet. We will be there someday.
Great, thank you so much. Well, I want to thank you both again for fantastic presentations and a really lively hour of discussion with our many participants. We're very grateful to both of you. I'm going to turn things back to Steve Moore for a moment so he can round us out with some final announcements, and then we'll close out for the hour. Steve?
Great, thanks everyone. Yes, it's just about time for us to wrap up here, everyone. We appreciate you joining us for today's webinar. Today's webinar is part of the National Alzheimer's and Dementia Resource Center series, which is sponsored by the Administration for Community Living.